Okay, very confusing. Okay, but we have to remember that the patients having atrial fibrillation look for OSA or obesity or obstructive sleep apnea. BMI is high. Apart from high BMI and atrial fibrillation, there is no uh, nothing like snoring and excessive daytime sleepiness or fatigue. There is no such feature present in this system. Okay. Okay, the development and the persistence of AFib is largely depend on the underlying remodeling, which involves both the structural and conduction system changes that results from aging and comorbidities. Obstructive sleep apnea likely contributes to atrial remodeling and is strongly associated with atrial fibrillation. Therefore, it should be considered in patients with atrial fibrillation and the risk factor for OSA BMI more than 30. The association of the OSA with atrial fibrillation may be due to nocturnal hyperventilation, stimulating hypoxic pulmonary vasoconstriction, which increases the pulmonary arterial pressure and can cause right atrial dilatation. In addition, the nocturnal hypoxemia caused by OSA is known to stimulate chronically elevated levels of sympathetic tone, which may contribute to increased atrial conduction automaticity, and increased triggering of atrial fibrillation. OSA is also strongly associated with other comorbidities that directly encourage atrial fibrillation, hypertension, heart failure with preserved ejection fraction. Identification of OSA is important and its treatment, weight loss, nocturnal continuous positive airway pressure, may assist in the management of atrial fibrillation. Got it? Yes. A plasma free metanephrine level can be used to evaluate for pheochromocytoma, which can encourage atrial fibrillation via increased automaticity of the atrial myocardium. However, pheochromocytoma is extremely rare, and this patient has no other suggestive signs and symptoms: headache, sweating, hypertension, making OSA a far more likely contributor to his atrial fibrillation. He's on aspirin, isn't it? Okay. Yes. Or clopidogrel, kind of aspirin type of work. And okay, this patient has multiple risk factor for coronary artery disease, age more than 50, diabetes, smoking history, and the chest pain, ischemic ECG changes, and elevated troponin level are diagnostic for non-ST elevation MI. The acute management of non-ST elevation MI involves a medical management usually followed by prompt by non-emergency coronary angiography, often within 24 hours, to evaluate the atherosclerotic coronary anatomy and determine the need for stent placement or coronary artery bypass grafting. This patient opts for medical management only. This patient opt for medical management only. Initial medical management should include beta blocker metoprolol to reduce myocardial oxygen demand, auto anticoagulation to reduce thrombus formation, and anticoagulation to reduce thrombus formation, and high intensity statin atorvastatin to stabilize atherosclerotic plaque. In addition, dual antiplatelet therapy with aspirin and P2Y12 receptor blocker clopidogrel, prasugrel, ticagrelor should be given to reduce antiplatelet therapy. In patient planning to undergo coronary angiography within 24 hours, withholding the initiation of the P2Y12 inhibitor therapy until until after the procedure is often reasonable, because patient in whom CABG is indicated must delay for surgery for at least 5 days if they have already received a P2Y12 inhibitor. So this is important information. Like in patients planning to undergo coronary angiography within 24 hours, withholding the initiation of the P2Y12 inhibitor therapy until after the procedure is reasonable, because patients in whom CABG is indicated must delay surgery for at least 5 days if they have already started P2Y12 inhibitor. In patient who had declined PCI, a P2Y2 inhibitor should be given without delay. Okay, preferred approach. Look at the box inside the CABG. Sorry, yes. If somebody comes with chest pain, looks like cardiac chest pain, first of all, antiplatelet therapy like aspirin, four dose of four like loading dose of aspirin, loading dose of atorvastatin, like loading dose of lipid lowering agent. These two, uh, yes, yes, and we actually give the clopidogrel also. Four aspirin, four clopidogrel, and four dose of statin. These three is given, and then after that we do the ECG. We can do ECG before giving that, but we do the ECG. If in the ECG you get the right, what can I say, inferior MI. So when you find inferior MI, you have to be cautious before giving beta blocker, because it causes bradycardia, it causes hypotension. You should be cautious about giving nitrate, like beta blocker and nitrate, like first two in These two is usually avoided if it is inferior MI, but other MI you can give blindly. But if the patients like, what can I say, patient, sorry, no, we don't get anticoagulant. Anticoagulant actually given for if the non-ST elevated MI. Anticoagulant is preferred in non-ST elevated. There is immediate management, there is delayed management. In the I am telling about the immediate management. The delayed management, the low molecular weight heparin for non-ST elevated MI, and for ST elevated MI you can give you can do either PCI or you can give thrombolysis. If the PCI is not possible, if you are in such a setting where PCI is not possible and you are not able to send the patient to other hospital, then you have to give a fibrinolytics like altiplase, retiplase, tenactoplase, like thrombolysis. So for ST elevated MI, these are the things, and for non-ST elevated MI, we should go for the unfractionized heparin, or we should go for low molecular weight heparin. Got it? Non-ST elevated MI, they have said that coronary angiography often within 24 hours. So if in a hospital there is a possibility of doing the angiography, coronary angiography, like in Bangladesh, in with those hospital where there is angiography facility, they can do PCI. But in those hospital there is CCO, but there is no angiographic facility, so they are not able to do the angiogram, so they give the thrombolytics. Got it? Yes, it is not for ST elevated MI. In ST elevated MI there are two options. In ST elevated MI, either do PCI. Look, they have written the PCI in the box. In the box, yes. PCI less than 90 minute, first medical contract, or second option is fibrinolytics if PCI is unavailable. That's clear. Got it? Yes. Yes. We why you are giving? There is the look. The non-emergency PCI intervention within 24 hours is recommended. We recommend him PCI, but he refused because there is a problem, like may not have the covering. Like in USA, PCI is very costly, so you need that type of insurance to cover that PCI to be done, isn't it? So as he is not able to do the PCI, he declines. So you need to give something that covers him. That's why we start the dual antiplatelet therapy. We are giving the dual protection. And if we are able to do the PCI, again we will give the dual antiplatelet therapy. But it will given after PCI. But as he is not, as he is refusing to do PCI, that's why we are giving earlier. Got it? So just make in a simplified manner. I know I am explaining a lot, but think in a simplified manner. Like PCI, how PCI is done. PCI is done via doing the angiography. When the cardiologist do angiogram, at that particular setting, they are capable of doing PCI. Like my father have has done PCI. So first they have done angiogram, then the cardiologist came and told us there is this type of block, and are you going to do the PCI now, or you are going to do the PCI later? So that's my decision. If I say that I will do PCI in that setting, then he will do the PCI, and if it is not possible, then we can do it later. After doing angiogram, you need to have that decision, either you have to do the PCI or not. Got it? So as it is non-ST elevated MI, so angiogram has done, so the surgeon cardiologist has told him to do the PCI non-emergency. It is not emergency PCI. You have to understand between the emergency PCI and non-emergency PCI. Emergency PCI is you have to do it now, like ST elevated MI. In ST elevated MI, you have to do it PCI now, but in non-ST elevated MI, you can do the PCI later on, like after 1 week. And as you are doing PCI after 1 week, you can go for antiplatelet, you can go for low molecular weight heparin for the last 5 days, and then you do PCI, and then you can start the dual antiplatelet therapy. That's the protocol. I don't know you understand or not. Okay. Okay, look at the preferred approach for non-emergency coronary revascularization, like stent place. Yes. No, 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 this, no, not this one. So your question, yes, yes. The is medical management is like first the regular medical management, like that drugs, aspirin, atorvastatin. If a patient has high blood pressure, beta blocker, these are the medical management. And along with, as it is non-ST elevated MI, you can start low molecular weight heparin, like anticoagulation. No, no, this box is very confusing. This box has multiple clues. They are written in such a manner that you will not gonna understand. Angiography. Yes, yes. Coronary angiography is an invasive procedure. Yes. On that setting, you can do reperfusion or you can do it later. Like you do coronary angiography. Why we are doing coronary angiography? To look for the block, like which artery is blocked and how much blocked. Like LED, like cardiologist told you that LED is blocked like 30%, 40%. What you will do in that case? You will do nothing, because 30%, 40% block needs do not need the PCI. In that perspective, you can continue the low molecular weight heparin. After 5 days of low molecular heparin, the patient can go to home. Got it? If the LED is blocked near about 90%, like if the LED is blocked more than 90%, like LED is the main single vessel disease, LED is blocked more than 90%, or more than two vessel, RCA or LCX, most two vessel is blocked, then we can do stent placement. But when we are preferring CABG, we are preferring CABG when there is three vessel disease like LAD, RCA, L6, and most left main artery disease, and two vessel disease involving LAD in patients with diabetes. So two vessel disease involving LAD in patients with diabetes, we will do CABG, not stent. It is written in another box. I have read that box. Okay, got it? Okay, this is pulmonary embolism. So causes of, if we look at the box like modified Wells criteria, PE, if PE is likely, then CTPA, CT pulmonary angiogram. If it is positive, that means pulmonary embolism confirmed. Negative, PE excluded. If PE unlikely, then you can do the D dimer. If D dimer is less than 500 nanogram per ml, PE excluded. More than 500, then you can do CTPA. Okay, causes of pleuritic chest pain include costochondritis, pericarditis, malignancy, infection, pneumonia. Pulmonary embolism is a relatively common life-threatening cause of pleuritic chest pain. Life-threatening cause of pleuritic chest pain should be strongly considered in patients with risk factor, recent hospitalization with prolonged immobilization, The evaluation of suspected P requires an assessment of pretest probability. The patient has several features that are highly suggestive of pulmonary embolism, include dyspnea, tachycardia, tachypnea, unilateral lower extremity edema, pleural effusion, low-grade fever, and troponin elevation. Pleural effusion, low-grade fever, troponin elevation can also be seen. These features all make pulmonary embolism is likely explanation of his presentation. Therefore, using the modified Wells criteria, and this patient has likely probability of the PE, heart rate more than 100, recent hospitalization, prolonged immobilization, altered diagnosis, less likely to PE. So he has pulse, high pulse, recent hospitalization. These are the these are the criteria for pulmonary embolism. Okay, modified Wells criteria, pretest probability of the pulmonary embolism, clinical signs of the DVT, and alternate diagnosis less likely than the DVT. 3 plus 3. Previous PE or DVT, heart rate more than 100, 1.5, and recent surgery or immobilization 1.5. And 1 point for hemoptysis, 1 point for cancer. If it is more than 4, it is PE likely. Less than 4, less or equal 4, PE unlikely. So this so CT pulmonary angiography is indicated as high diagnostic accuracy in such patient. Ventilation perfusion scan is less accurate, alternating for diagnosis with significant renal impairment, morbid obesity, and contrast allergy. D-dimer testing is useful in excluding pulmonary embolism in patients with low pretest probability, but it has no utility in the setting of high pretest probability due to an unacceptable rate of false negative results in such patients. Got it? Yes. Option B, D, E. The patient is at risk of recurrent acute coronary syndrome. Emergency and coronary angiography is indicated for ST elevated myocardial infarction due to stent thrombosis. However, these should present with ST elevation on ECG and ischemic pressure like unchanged with breathing, chest pain rather than pleuritic chest pain. Serial ECG and troponin levels or stress testing are indicated for suspected non-ST elevated MI or unstable angina, but these SAS manifestations should also present with ischemic rather than pleuritic chest pain. Option C, post-cardiac injury Dressler syndrome is an immune-mediated pericarditis. Immune-mediated pericarditis that can occur several weeks following MI or cardiac injury, and is treated with and is treated with non-steroidal anti-inflammatory drugs and colchicine. It typically presents with pleuritic chest pain and fever, but often causes ST elevation on ECG and would not explain this patient's unilateral lower extremity edema. Acute PE is most likely must be evaluated. Got it? Okay. So digoxin toxicity can cause wide range of cardiac arrhythmia. Digoxin toxicity has wide range of cardiac arrhythmia like sinus bradycardia, junctional rhythm, ventricular tachycardia. Almost most of the arrhythmia can occur in variety of the clinical setting and non-diagnostic of digoxin toxicity. Atrial tachycardia with AV block is non-specific. AV block is non-specific for digoxin overdose and is generally considered for diagnostic toxicity in patients in patient taking the medication. The effect of digoxin toxicity on the heart are complex but can summarized as follows. It can cause atrial tachycardia. Atrial tachycardia is likely due to increased automaticity of the conduction in the atria. The focused increased automaticity may be located within the sinus node, resulting in P wave abnormality, resulting in P wave morphology similar to that of normal P wave or within a part of atrial myocardium, resulting in different P wave morphology. The rate of atrial contraction is typically around 200 per minute, which is slower than atrial flutter, typically more than 300 per minute. AV block likely results from directly increased vagal tone, causing slowed conduction through AV node. The AV block can be first, second, or third. Obese type 2 second degree block is almost never seen in digoxin toxicity. When second degree block is present, it is typically Mobis type 1. So 1 to 3, anyone can happen, but type 2, like second degree type 2, cannot be happened. And other arrhythmia also involves on similar mechanism of increased automaticity in the myocardium, ventricular tachycardia, and or increased vagal tone, sinus bradycardia. Because digoxin competes with the potassium, to bind to the myocardium at the sodium potassium ATPase pump. Sodium potassium ATPase. Hypokalemia increases digoxin binding and can worsen or cause it to a lower than expected serum digoxin level. Got it? Okay. Uh, this is the sine wave on ECG. Sine wave pattern. That's why this is the hyperkalemia. Okay. Look at the progression of the ECG in hyperkalemia. Hyperkalemia is a medical emergency. Look at the ECG pattern, progressive changes on hyperkalemia. Okay. First, PR prolonged PR interval. And if we find PR prolonged, we may think about block, isn't it? Okay. PR prolonged, but there is tall peaked T wave. PR prolonged and tall peaked T wave. Think about hyperkalemia. In hyperkalemia, there is tall tented peaked T wave. First of all, PR is prolonged. Then loss of P wave. Loss of P wave, ST segment depression. And again, the T wave is tall peak T wave. T wave is just equal to the QRS complex. And the third one is sine wave pattern, white QRS complex. Look at the white QRS complex. Normal QRS complex is 120 millisecond. It is wider from one point to this point. It is wide QRS complex. Okay, it is sine wave pattern, and finally the asystole pattern. That's why we are giving calcium gluconate to block the cardiac impulse, because it will end in diastolic failure. In hyperkalemia, calcium gluconate is given not to restore the potassium. It is given to save the heart and to stop the diastolic failure. Okay. Now, the patient with diminished food and water intake developed by dry mucous membrane, hypotension, confusion, indicating hypovolemic shock. Hypovolemic shock. Okay, 1 second. I'm calling you within 30 seconds. Got it? Okay. Okay, this patient, I'm an, okay, this patient with diminished, you haven't shared your screen. Okay, now, yes, now. So this patient with diminished food and water intake developed dry mucous membrane hypotension dry mucous membrane hypotension confusion, indicating hypovolemic shock. Severe hypovolemia can often cause significant electrolyte abnormality, hypernatremia or hyponatremia, hyperkalemia, metabolic acidosis due to GI electrolyte loss. GI electrolyte loss, increase antidiuretic hormone and AKI. In this case, the presence of no P wave and sine wave pattern, on ECG consistent with hyperkalemic emergency. Hyperkalemic emergency usually arises when serum potassium is more than 6.5 and it is marked by altered repolarization of the skeletal and cardiac muscle, which leads to lethargy, muscle weakness, cardiac arrhythmia, and progressive changes on ECG. Peaked T wave, loss P wave, widened QRS, sine wave pattern, and finally assisted. So first tall peak, then loss of P wave, tall peak, loss of P wave, widened QRS, sine wave pattern, and assisted. Okay. Patient with hyperkalemia-induced ECG changes require urgent treatment with calcium gluconate to stabilize the calcium to stabilize the cardiac membrane and insulin plus glucose to drive potassium into cells. The This temporarily counters the cardiac abnormalities, which provides time for removal of potassium from the body via stool, pathyromer, urine fusamide, and blood hemodialysis. Yes. Okay. Patients with complete heart block who are bradycardic and hypotensive are treated with atropine. Patients who complete heart block who are bradycardic and hypotensive are treated with atropine. Transcutaneous pacing is used for those who do not adequately respond because this patient's heart rate is normal and her hypertension is unlikely to significantly improve with atropine and transcutaneous spacing. In addition, the lack of P wave on ECG is highly suspicious for hyperkalemia. Treatment with calcium gluconate and insulin plus glucose should be attempted prior to the therapy. Yes. Okay, so this patient, can you hear me? Okay, this patient who recently underwent coronary artery bypass grafting have evidence of separation of sternal wound like sternal dehiscence. Wound dehiscence after CABG is a relatively common complication, and management is determined by extent of tissue involvement. Soft tissue dehiscence and sternal dehiscence. Soft tissue dehiscence occur when only the superficial tissue, skin, muscle separate, and there are no signs of sternal instability or systemic illness. Local wound care or debridement followed by primary closure is indicated, and sternal dehiscence occurs with a separation of the edges of the approximated sternum and may occur with or without soft tissue dehiscence. Sternal instability and non-union is characterized by clicking or rocking on sternal palpation. It's a surgical emergency and it requires sternal rewiring to prevent cardiac trauma. A high mortality complication of dehiscence is a deep tissue infection mediastinitis due to either contiguous spread of the superficial infection or intraoperative deep tissue contamination, although it classically presents with systemic symptom fever, tachycardia, chest pain, chest wall edema crepitus, and purulent wound discharge. An atypical presentation can occur. Therefore, any patient with significant sternal wound drainage should be evaluated with chest wall and sternal imaging, mediastinal fluid collection on pneumomediastinum on CT scan. Management include emergency surgical debridement, tissue culture, and empiric IV antibiotic. Yes, topical and oral antibiotic do not have a role in the management of post-operative wound infection due to the risk of underlying deep tissue infection. Broad spectrum IV antibiotic should be initiated if mediastinitis is suspected, but in this hemodynamically stable patient with no signs of sternal instability, imaging and culture should be pursued first to confirm the diagnosis and guide management. Okay, this this newborn has a mild respiratory distress. This newborn has a mild respiratory distress and systolic ejection murmur with sonographic evidence of interventricular septal wall thickening consistent with hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy. Infants of the mother with gestational diabetes. Infants of the mother with gestational diabetes are at risk of developing transient HCM. Exposure to excess glucose in utero. Exposure to excess glucose in utero leads to fetal hyperglycemia, hyperinsulinemia, and increased fat and glycogen deposition, and that is prominent within the interventricular septum cardiomyocyte causing HCM. Although most affected infants are asymptomatic, some develop heart failure due to severe left ventricular outflow tract obstruction, respiratory distress, hypotension, systolic ejection murmur. Other neonatal consequences of maternal diabetes may be macrosomia and plethora due to polycythemia. Management of at symptomatic HCM is aimed at increased left ventricular volume in order to alleviate left ventricular outflow tract obstruction and improve cardiac output. It includes intravenous fluid and beta blocker propanolol. Beta blocker reduce the heart rate negative chronotropic effect which increases left ventricular diastolic filling time as well as end diastolic volume preload. In addition, the negative effect of beta blocker decreases the pressure gradient because left ventricular outflow tract and aorta, further reducing the dynamic left ventricular outflow tract obstruction. Treatment is rarely required for more than a few weeks because insulin levels quickly normalize, leading to a reduced septal thickening and self resolution of HCM. Got it? Okay. Patient age more than 60, smoker, men with a history of atherosclerosis or connective tissue disease are increased risk of abdominal aortic aneurysm, which typically causes few symptoms until it markedly expands or ruptures. Pain is most common initial manifestation and can vary according to aneurysm location. Proximal aneurysm tend to present with upper abdominal, flank, and back pain, whereas distal lesions presents with lower abdominal or groin pain. In the event of rupture, hemorrhage usually occurs into the retroperitoneum because the expanding hematoma may be temporarily contained within the retroperitoneum. Within the retroperitoneum, patient may remain hemodynamically stable and have delayed presentation as in this case. Other others clue to the diagnosis of abdominal aortic aneurysm include a pulsatile abdominal mass present in slightly over half of the patient and prevertebral aortic calcification on plain X-ray and consistent with extensive atherosclerosis. In the symptomatic patient who are hemodynamically stable, the diagnosis should be confirmed with abdominal CT. Hemodynamically unstable patient require emergency surgical repair. Hemodynamically unstable patient require emergency surgical repair with confirmation obtained by rapid bedside ultrasound if necessary. Yes. Okay. So these patients acute neurological symptoms, weakness of dysarthria with imaging studies that reveal multiple subacute strokes and cardiac vegetation indicate embolic stroke due to endocarditis. Although most cases of endocarditis are infectious, these patients' lack of fever, leukocytosis along with negative blood culture and PCR testing make infection less likely. Given his advanced stage, low BMI, extensive alcohol and tobacco use, the patient most likely has non-bacterial thrombotic endocarditis due to undiagnosed malignancy, that is, lung or pancreatic cancer. Non-bacterial thrombotic endocarditis is a non-infectious endocarditis that most commonly develops in patients with advanced cancer, often adenocarcinoma or systemic lupus erythematosus. These conditions cause a hypercoagulable state which promotes platelet deposition on healthy cardiac valves. Now, because inflammatory cells are not strongly recruited to the area of platelet attachment, the thrombi are particularly prone to detachment and embolization. Most patients are asymptomatic until emboli travel to the kidney, spleen, and extremities or brain. Significant valvular insufficiency, heart failure murmur is common. Echocardiography usually reveals several small mobile vegetation on the aortic and mitral valve. Workup should include evaluation for a hypercoagulable state, antiphospholipid antibodies, and investigation for malignancy. CT scan of the chest, abdomen, and colonoscopy. Treatment involves management of the underlying cause and anticoagulation to reduce the risk for thromboembolism. Next. In this system, we always skip one thing. Can you tell me? Yes. Okay. So digoxin is effective in treating atrial fibrillation and heart failure with reduced ejection fraction. However, the drug has a narrow therapeutic index and toxicity is common because digoxin is renally cleared, and elderly patients to who are susceptible to dehydration and acute kidney injury are um, particularly prone to toxicity. Acute digoxin acute digoxin toxicity acute digoxin toxicity most likely sorry acute digoxin toxicity Most commonly presents with GI symptoms, anorexia, nausea, and vomiting, as well as lethargy and fatigue. So chronic toxicity, neurological, visual, and cardiac arrhythmia can happen. Sinus bradycardia can happen. AV block can happen. Are common in toxicity, may cause palpitation. This elderly patient is at risk of dehydration due to use of furosemide. She has experienced reduced digoxin clearance and leading to acute toxicity. The collection of blood digoxin level helps to confirm the diagnosis. However, toxicity can occur even with normal blood level. In such cases should be recognized by consistent clinical feature. Treatment involves a drug discontinuation, IV dehydration in severe cases, and administration of DIGFAB. Got it? Okay. Let's take a break. Okay, you have given me